Welcome and thank you for joining us today for the release of our latest report, Filling the Gaps in the Behavioral Health Workforce. My name is Marilyn Serafini, and I'm Executive Director of the Health Program here at BPC. The behavioral health crisis in our country is real. We're talking here about the huge unmet need for both mental health and substance use services. We must expand our thinking beyond the traditional behavioral health workforce, where we have a severe shortage of psychiatrists, psychologists, clinical social workers, and others. That's exactly what the BPC has done with this report. In this new report, we consider behavioral health professionals beyond the licensed workforce and examine federal levers to expand the ways their services can be best utilized to ensure more Americans with behavioral health needs receive care. We believe our report comes at a crucial moment. The U.S. continues to face a shortage of licensed behavioral health care specialists. At the same time, we are seeing rising rates of mental illness and substance use disorder. As of March 2021, more than 1/3 of Americans lived in mental health shortage areas. During the pandemic, rates of mental illness spiked by 41%, and overdose deaths increased by around 30%. With licensed providers in such short supply and stretched to their limits, Congress and the Biden administration have taken steps to expand the behavioral health workforce. For example, as a part of his unity agenda, President Biden articulated the importance of peer specialists and community health workers. The administration's 2022 National Drug Control Strategy cited peer specialists as an important mechanism for building trust and reducing stigma among those suffering from addiction. Congress is also hard at work on this issue. On Capitol Hill, lawmakers have proposed legislation such as the PEERS Act and the Pursuing Equity in Mental Health Act. Both of these aim to strengthen the role of behavioral health support specialists. Federal funding from the American Rescue Plan Act and for health formula grant programs have followed suit. Late last year, Congress also added Medicare coverage for licensed mental health counselors and marriage and family therapists. Some private insurance already covered these providers and some Medicaid, but not in Medicare. Policymakers must continue offering solutions looking beyond the traditional behavioral health specialists and looking into the community. We need to meet people where they are. We believe the recommendations that we offer in this latest report will help lawmakers accomplish this goal, which we know is a priority for them. Our discussion today will focus on these recommendations. The new report is aimed directly at bolstering what we are calling behavioral health support specialists. This includes peer specialists or peer support and recovery specialists, community health workers, and paraprofessionals. This also includes members of the community offering services through community-initiated care. You can access our report at bipartisanpolicy.org. Our recommendations fall into 5 basic areas. First, building a set of national core competencies for behavioral health support specialists. While states will need to establish their own requirements for these specialists, the states can use the federal core competencies as a guidepost. Second, creating pathways for coverage of behavioral health support specialists within Medicare and Medicaid and through enhanced data collection and technical assistance. Third, creating a pipeline program to assist behavioral health support specialists who want to become licensed practitioners. Fourth, establishing a community-initiated care specific demonstration grant through existing, or it could be a new demonstration program at the Centers for Medicare and Medicaid Services, their Center for Medicare and Medicaid Innovation. And fifth, integrating federal funding streams that support CIC-related programs and programs that support the work of behavioral health support specialists. I'd like to extend a special thanks to Providence's Wellbeing Trust for their support of today's event and our newest report. Thank you to today's speakers, our many expert contributors, and of course, the BPC Health Program staff. Now, I'd like to welcome Dr. Ben Miller. Ben is a clinical psychologist by training who has spent 2 decades working to ensure mental health is prioritized in policies, program, and investments. He's the chair of the Inseparable Advisory Board, a group that's devoted to advancing mental health care policy. He's also an adjunct professor at Stanford School of Medicine. Previously, Ben served as the president of Wellbeing Trust and as an associate professor at the University of Colorado Department of Family Medicine. Okay, let's turn it over to Ben.
Thank you, Marilyn, and welcome everyone to this important Bipartisan Policy Center release. As many of you know, our workforce is an essential and foundational component for any attempts to address the health of our nation. Without a rethinking of who does what, where, and for whom, we remain in a place of stasis, stuck thinking that we will someday have the solution to the never-ending supply and demand problem that Marilyn referenced. With the emergence of promising practices, technology, and the public's openness to embracing mental health, now is the time to really move towards a more radical approach to our workforce. While at Wellbeing Trust, I prioritized our work with Bipartisan Policy Center because I knew that so many of the rate-limiting factors bringing new models to scale was the political and policy direction. BPC's work with us in the past on mental health and primary care integration had a major impact on the national dialogue, with many of the policy recommendations becoming adopted solutions. So today, it's another one of those big steps. This report, it pushes us a bit. It forces us to really go beyond traditional architecture on who helps address mental health in our communities. And there are a few things I think you should listen for today. First, listen for the framework. It's important. The addition and expansion of our workforce requires a pretty strong understanding of how the pieces fit and the various pathways a person can take to get the right person to care at the right time. The workforce that we'll describe today that you'll hear are complementary, and they're complementary to the existing system and existing structures. While they challenge us to think beyond the traditional walls of a clinic, in the end, they're all working to do all they can to help the person in front of them. And there's plenty of work to go around. As our communities know all too well, while we wait for help, too many of us languish. There has to be more of an immediate way to get help. This is a tenable solution to do just that. Second, listen for the language. When we started doing work around community-initiated care, we were always very clear that this was care in community, by community, for community. It was a chance to shift the power, to flatten the traditional hierarchy that exists in healthcare, and to empower communities to have the skills to be able to help one another. There's a precedent for this, a scientific basis. We just haven't been able to scale these approaches here in the US, not yet. So the work you'll hear today is a new line in the sand, a new policy document to enable us to move beyond ideation, evidence, and actually put policies in place that can make the vision of a new workforce a reality. And finally, today, listen for possibilities and places for you to engage. We all have a role to play in this new approach if we're going to be successful. I know for me, I plan to take a lot of these recommendations, apply it to a new company that I'm doing that really focuses on scaling these models across the world. This is vital work that can make a huge difference in how we conceptualize health and care. We shouldn't expect that the future of mental health is going to be found in a new building or a new clinic or just a new program. The future of mental health is one that comes deep from our past. It's in our relationships that are grounded in the context of family and community. Let's take advantage of the power of these relationships and use them as a platform to build out new and novel approaches to mental health in our workforce. We have the science, we have the technology. Let's rapidly scale these solutions across the globe. The question is, do we have the courage? So my thanks to Bipartisan Policy Center and all the excellent partners that have been engaged in this from the beginning. Really bringing this work to light is a major step in the right direction. To our countless experts, policy and beyond who are engaged, thank you. And thank you for watching and being here today and helping us advance mental health. Marilyn, back to you.
Thanks so much. So we're going to hear now from Congresswoman Judy Chu of California.
Hello, I'm Congressmember Judy Chu from California's San Gabriel Valley, and I'm so glad to be joining the Bipartisan Policy Center to mark the release of your behavioral health report. As one of the few psychologists in Congress and a member of the House Ways and Means Committee, I want to say thank you for the incredible work that BPC does to compile this report, which will help guide policymakers as we seek to close the behavioral and mental health treatment gap. Americans, especially those suffering from mental health and substance use disorders, are still coping with the behavioral health impacts of the COVID-19 pandemic. In fact, as many as 40% of adults surveyed reported symptoms of anxiety or depression during the pandemic, which was up from 10% of adults in 2019. Business closures, job loss, and prolonged periods of isolation had a devastating impact on the mental health of Americans in every state. And so our job in Congress must be to address the enormous need for mental and behavioral health services in this country. That is why last Congress, I was so proud to introduce H.R. 2767, the Bipartisan Peers in Medicare Act, with Representative Adrian Smith of Nebraska. This bill would clarify that there is nothing in current law that prevents peer support specialists from being included in coordinated care teams under the Medicare program, which serves our senior population. A peer support specialist is a person with lived experience who has been trained to support those who struggle with mental health, psychological trauma, or substance use. This personal experience provides peer support specialists with expertise that professional training cannot replicate. Peers do not replace clinicians the way psychologists or psychiatrists do, but they can bolster the mental health workforce at a time when it is already stretched thin. For example, if someone comes out of long-term treatment for a substance abuse disorder, they could find themselves alone in an empty apartment just hours after completing treatment. At these moments when people are susceptible to feeling isolated, scared, and probably a little uncertain about the future, being able to reach out to a peer support specialist in that moment to talk about how they are feeling can be the difference that helps them make it through those first few hours of recovery. I'm thrilled to say that the omnibus government funding bill that was passed by Congress at the end of 2022 included additional funding for peer support services in certain settings. This puts us one step closer to peer support specialists' full integration into Medicare. And I look forward to reintroducing my legislation and working with my bipartisan colleagues in Congress and partner organizations like the Bipartisan Policy Center to continue to improve behavioral health care in this country. Thanks to your work, we can identify areas of need and opportunities for improvement so that every American has access to the mental and behavioral health services they need. Thank you.
Thank you, Congresswoman Chu. We appreciate your efforts in this area. So let's turn to our panel for a discussion. I'd like to introduce our expert panelists. First, we have Karis Myrick. Karis is Vice President of Partnerships at Inseparable, which is a mental health care policy coalition that's dedicated to expanding access to care and health equity. She also serves as the board policy liaison for National Association of Peer Supporters. Dr. Gary Belkin founded and leads the Billion Minds Institute. The Institute aims to advance policies, science, tools, partners, and innovation to grow a robust social climate and mobilize around environmental change. And it's at Columbia University. He was the former Deputy Health Commissioner for the New York City Department of Health and Mental Hygiene and is a psychiatrist by training. And our third panelist is Marissa Wiesel. Marissa is Deputy Director for Strategic Initiatives at the Ohio Department of Medicaid. Now, we're going to talk a little bit with our panelists, and then we're going to give you plenty of opportunity to ask questions. And here's the way that you do that. If you are watching on YouTube, you can enter your question into the live chat, and we will see that. You can also submit your question on Twitter using the hashtag BPCLive. Okay, let's dive in. Let's first talk about the impact of the behavioral health workforce shortage. How has the behavioral health, and here I just want to be very clear, we're talking about both mental health and substance use. How has the behavioral health workforce shortage impacted Americans? What does this problem look like on the ground for people? And let's start here with Gary.
Thanks, Marilyn, and hello, everyone. It's been tragic. We're seeing numbers, prevalence of mental illness, substance use, overdose, suicide that is just exceptional, that we really have not seen before. And people don't know where to turn. We have a chronically hard to navigate system that is coming home to roost in not being there at a really critical time in public health in this country, and especially in mental health.
Yeah. So why focus on behavioral health support specialists and not just increasing the supply of the licensed workforce? We all know we need more psychiatrists and psychologists and licensed folks. But why this focus, Karis?
Yeah, I mean, and first of all, thank you for inviting me to come and be a part of the panel. But I think, there are so many needs that people have that are beyond just what licensed professionals may focus on. So we know there's social determinants of health needs. We know that there's loneliness. We know that people are looking for, we hear about people, place, and purpose, those sorts of things. And, being able to meet people where they are in the community and support them in the community in a variety of ways is the essence of what peer support specialists do, or peer supporters, community health workers, as well as other non-licensed professionals. So I think there's a prevention part of it too, like being able to meet people earlier on, as well as throughout the whole continuum of care and even into crisis. And then also, I think as we look at these numbers, we also have to think about cultural and language barriers. And here's where community health workers, especially promotoras or promotoras like people can meet folks in the community that are culturally and linguistically aligned. And I think those are some of the reasons as well.
Karis, will you do us all a favor and take a half a step backwards and explain to us what you mentioned a couple of different types of folks
Sure.
on the ground. Explain to us what they are and what they do.
Yeah, so we heard what peer supporters are from Judy Chu, but peer supporters are people with lived experience of mental health and or substance use conditions, or family members of children or adult children with mental health or substance use conditions who are trained to support folks on their recovery journey and in using that lived experience with intention. They're also community health workers, which generally are people who have other types of peerness, meaning I'm from the same community, I'm a cultural broker, I speak the same language, or I quote unquote look like you. Like those are some other ways in which a community health worker has a level of peerness or affinity to somebody else in their community. Promotores, who I brought up as a distinct group of community health workers, are generally found in the Latino community or Latinx community. And again, they are community health workers that are culturally and linguistically aligned from that Latinx perspective. And their work generally is around like health promotion and mental health promotion, helping people maybe get connected to resources via referral. So there's a little bit difference too between a peer support worker who can support people in the community. They can work within mental health settings. They can actually work in carceral settings as well as in crisis settings. So they work across the board, and they also are working on integrated teams. So they can also do team-based work alongside psychiatrists, social workers, et cetera. So they're really meeting people where they are. There's a lot of trust and building of trust because, wow, that person's been through what I've been through. So they're also building of trust where there may not be a lot, especially when you're a little afraid to tell somebody about having a mental health condition and or how people may stigmatize mental health conditions. So it can make it easier and more comfortable for people to talk to somebody who looks like them. And let's say you don't even know you have a mental health condition, and you're speaking to somebody like a community worker who's there in your community, just telling them what you're going through can help you feel less alone as well.
Oh, great. Thank you, Karis. Very helpful. Marissa, what are you seeing in Ohio? How significant is this problem, and what are you all doing in looking beyond the licensed workers?
Thanks for having me here, Marilyn. In Ohio, like the rest of the nation, we have an unprecedented need for mental health and substance use disorder care. We've certainly seen skyrocketing rates of all sorts of conditions that people have, and we are certain that many are still going undiagnosed because of lacks of access to care. We especially see this in the population of people that I care about and that many care about, those who have Medicaid. For a long time, we've had a greater prevalence of mental health and substance use disorder conditions within the Medicaid population. And this is a group of people who often lack access to care because of a lack of providers who are willing to work with Medicaid. And then there are, of course, other barriers in accessing the care that they need. Lack of transportation, childcare, housing, those sort of social determinants or social related needs of health that really can be barriers. And so I think that we see in the population in Medicaid that it's even harder now to access care now that the prevalence has increased and some of those social determinants are getting in the way. We really see this in our child population too. If we think about Medicaid, in Ohio here, we cover 1.3 or 1.4 million children, and over a quarter of them have a mental health or substance use disorder need. So we use our paraprofessionals, our peers, our community health workers to be able to extend our workforce, to extend what our licensed folks do, but also to make the services better. As a couple of folks have alluded to today, some of the best practices that we have in this space are really embedding peers or paraprofessionals into the evidence-based models. So in substance use disorder residential treatment, we know that peers can actually help people have better outcomes. Same thing with our mobile response service that we're building out for kids. When they have a crisis, having a peer go out to a home with a licensed individual really helps that family feel much more comfortable with having someone come into their home and see what their home is like. Sometimes we don't want people in our homes, of course, and that can be really uncomfortable, but we also need help. So it can make us feel a lot better when there's a peer involved.
So peers is not a new thing. And we have some of this going on. So you did mention outcomes, better outcomes. Let's talk with our other panelists about what kinds of evidence they see that already support the expansion to these workers.
Well, I'll jump in and really getting off something that Karis said about there are these so many other factors that determine whether somebody recovers that are not in the toolkit of psychiatrists, psychologists, of a lot of professionals have sort of anchored the system and been the kind of center of gravity for the system for so long. And so this opportunity in this moment of crisis to really rethink the workforce is really critical because for two reasons. One is that we're not having a child mental health crisis because we have a lack of child psychiatrists. We're not having huge overdose rates because we don't have enough substance use counselors. We're having it because huge transformational and difficult change is going on in a lot of parts of the country. And so a solution, a workforce solution, needs to include skills and tasks that get at what's driving this surge of emotional and mental damage. And so if they're not part of what we call the care system, then the care system is going to continue to not do its best in helping people. And so the evidence for these kind of alternative roles is one in helping people, in helping the care system perform better, essentially by filling in these connection gaps, these social service navigation gaps, these feeling heard and confident and trusting of the care system gaps, and just these reassurance gaps. And so that's one area where I think the evidence is pretty strong. Where the evidence is also strong, but we've been less bold, I think, to trust these other roles to handle is actually in treatment. There's most of the steps of treatment and care can be done by non-clinicians. And Ben was talking about to be spreading this already, to help accelerate spreading this idea of multiple skilled people and communities, to shift the power to the communities, to get care community centered. That means more than just helping people in the community navigate the care system. It's dispersing, putting the water skills in community members to do actual steps in care. And there, the laboratory, the evidence laboratory, is actually outside of the US, where there's a decade or two of deep evidence base that lay people, village members in rural India, people in cities in Africa, can learn how to do evidence-based treatment for depression, treatment for psychosis, can use counseling skills that are part of care and actually often the first best step for care. Some of that has happened in the US. Some, as Ben mentioned, it's been a little less in the water in the US, but there are places where it's been done. When I was Deputy Health Commissioner in New York City, we put that idea to scale in the city. We trained job training program counselors and daycare provider staff and teachers and peers who were peers not because of lived experience, but they lived in the same public housing residence, who would learn these skills to help their neighbors. And that's the first step. It's decentering where the work happens to the community, then just smoothing its center that's staying in a medicalized treatment system that doesn't have the fullest reach of capacity to meet all the needs that are driving people to seek care in the first place.
Karis, what is the best point of evidence that you know of to help us to understand the value of this?
Yeah, so I'm going to go through my spiel because it's the same one I've been saying for years, and I hope people can really take it to heart, the importance of the evidence that's already out there and continues to grow around peer support, which is that, of course, using peer support helps reduce stigma and shame, both for the person receiving services or who has a mental health or substance use condition, as well as for parents and family members who also struggle with their own sort of internalized stigma and shame. Also, it reduces use of high cost services. So when we talk about, wow, we're worried about the crisis system and the burgeoning, use of crisis services, peer support actually reduces use of high cost services and creates support for people to have longer tenure in the community. It also helps people in their own self-determination. So there's another kind of power word about being able to use their own autonomy. And one that I think excites people, especially kind of on the treatment side, is actually using peer support helps people partner in treatment because, and I hate to use the word adherence, but I'm going to use it, adhere within treatment because they're part of using shared decision-making and driving that treatment that they want alongside their provider. So I think that's a pretty powerful a piece of evidence as well.
And Karis, can you talk to us about, and this is actually our first question, which was a question of mine as well. How is this paid for? Who's paying for this? Is Medicare, Medicaid, private insurance? Are we paying for this? And is payment a barrier to expansion of this kind of partnership?
Yeah, so Medicaid, especially for peer support, Medicaid in certain states is used for peer support. And because of the Peers in Medicare Act, that's around clarity. It's not as if they couldn't, but just clarifying that you can actually utilize and bill for peers in Medicare. Private insurance is a whole nother ball of wax, and I don't want to get into the complexities of all of that, but in some areas, they have found ways to utilize peers within private settings, and I've heard even that there's a peer respite in New York that may also be supported within commercial insurance. So the other things that are used, sometimes there's grant funding, there's SAMHSA block grant funding. So there's probably braided and mixed funding that's used. The biggest issue, I think, is ensuring that, number one, that the rates can support a living wage and that they're career ladders for folks who are in these positions to make it attractive for them, just like it would be for any other position. So I think those are a couple of things to think about when we're thinking about what does the funding look like. And then also when we're using Medicaid, Medicare, or any type of insurance, not medicalizing the role of these supporters because they're not medicalized in that way. And sometimes that ends up with scope creep. And then lastly, or operating outside of your scope. And then the very last thing I will say is around supervision, that supervisors or whoever supporting the person or the person's reporting to has to understand the role and the training, and again, how to help the person stay within their scope of practice. Once you get outside of your scope of practice, then it becomes harder to actually get the fidelity to how these services, the fidelity of the outcomes that the services can achieve.
Yeah. So Gary, why should policymakers be emphasizing this part of the workforce, these non-clinical folks, rather than simply focusing on increasing the number of licensed providers? How do the two fill out the workforce together? And what does this have to do with, I mean, these are folks who are not going to get in and do the therapy. They're certainly not going to prescribe drugs. So they're not really there to supplant the licensed workforce, but why should policymakers look here?
Well, because we've learned that a system based in some key categories of licensed professionals who sit in key places in certain offices and in certain clinics is just not the right fit for the way people get better and for being close to what drives mental illness and the distress that people are bringing to begin with. If it takes a village to nurture people, it also takes a village to create the stresses that make it difficult. It takes a village and equipping a village to do this work. And so that means skilling up more people who can navigate where people are and bring skills to where they are. I liked also Ben mentioned at the outset, we have to ask the question, what are we going to do, where, and for whom? When I was reading the report, which was just a breath of fresh air and really thinking widely and creatively how federal levers can be put to work in creating this more accessible role. I did have a nagging, that nagging feeling that the mental health, that our habits, that certain habits of mental health policy are going to still kick in, that the center of gravity will still be staying in these focused, specialized places and offices, and the center of gravity will not shift to the community. And so I would even double down on the sort of scope you've been imagining for these behavioral health specialists, because they actually can do parts of therapy, and they can track symptoms with people, and they can counsel them. And we know that, and it's been done in lots of places. So the way to meet the scale and demand is to change the real estate of mental health work to come out of the clinic walls and offices and into neighborhoods and into the places where people trust who are looking for help, in their houses of worship, in their job training programs, in their YMCAs, in their schools, in their peer groups. That's who we have to equip. And I have to tell you, when we did that in New York City, psychiatrists and psychologists who partnered with those groups, who coached them, who provided backup to them, described having the most rewarding work professionally that they've had. Their knowledge, their skills spread further to more people than it ever would if they sat in their offices. And so we are wasting a lot of money in underpowering professionals to extend their reach, to extend the capacities of the communities that they work in. So we have an inefficient system that sees too few people, that is not spreading the skill set that we know the evidence allows us to do barely wide enough to meet the problem. So that should really keep policymakers up at night, is that that's okay, given the mental health crisis that we have.
Right. And, we had a comment from somebody in the audience that, it's interesting that we're using language to say licensed clinicians are not needed versus how to better leverage them to guide, lead, and help manage community initiatives. And I think actually we would agree with that. I think everybody, correct me if I'm wrong, but I believe everybody on the line would agree with that, that we really need a team-based approach to do this. But in looking again at policymakers' role and where their priorities are, last year in December, Congress expanded Medicare coverage for licensed mental health counselors and marriage and family therapists who already many Medicaid programs covered, and also much of private insurance was covering, but Medicare did not. And so that's where the focus of Congress was last year. Now, granted, they didn't do a major behavioral health care package, and we're hoping, and they are actually hoping to do more this year. But what is it that we need from Congress? What is it that we need to expand the role of this part of the team, the non-licensed part of the team?
I mean, I think part is what you're doing by creating more clearly defined categories of work. But what I would also suggest, thinking about it, that this move that you're making can open up a conversation about, is actually paying clinicians to do different things, to train clinicians to coach and train community members, to make it part of their reimbursable work. Because in my experience, that is the only obstacle to them not doing it. When they're given the opportunity to do that, when they're given the opportunity to empower others, spread their skills elsewhere, they're happy to do it. But we don't have the business model for it. And it's not that hard to come up with a payment system that allows them to do it. And we'll get much more bang out for our buck from them, including really enriching all these other kind of work roles to be more empowered and enable themselves.
And Marissa, let me turn to you. You're seeing this from the state perspective and Ohio's Medicaid program. And we know that states have varying degrees of certification requirements for their peer support specialists and community workers and paraprofessionals. Can you give us a sense of what state certification requirements look like, and how, one of the recommendations in our report is to create a national set of core competencies that could help states to, they wouldn't be a requirement for states, but would help states to, in the development of their own certification requirements.
Absolutely. So with the caveat that if you know one state Medicaid program, you know one state Medicaid program, I think based on differing geography, population needs, abilities of a workforce, and investment over time, I think all states have approached this a little bit differently. In Ohio, we have a certification pathway that runs through one of our state agencies to certify peer recovery supporters. We have certification that runs through our Board of Nursing for community health workers. And then we have organizational regulation for that supports the organizations where some of our other paraprofessionals work, which is to say it's not a hodgepodge. It's really a set of regulatory requirements that help us make sure we're getting to all the right people to be part of this workforce. And that kind of flexibility and deference to the states to be able to say, these are the competencies we want, but states need to be able to figure out how to do this on their own is really important, I think, for our federal partners to understand. We're having guidelines and having competencies, I think would be really helpful, especially for some states that haven't dipped a toe into this yet. But for those of us who have been doing this for a long time, we wouldn't want to exacerbate a workforce shortage by saying this part couldn't participate anymore. And I think we've learned a lot along the way as we've sort of been charting this course on our own state by state, it's really given us a lot of information that we'd be happy to share with our federal partners about what works well, what doesn't work well, which sorts of things can organizations and the licensed clinicians within them and their boards of directors handle versus what's better to be at the state level. I think much like scope of practice is something that is left up to states. I think that's a pretty good model. But again, having some additional guidance at the federal level would be really helpful, especially for states that haven't done this yet.
Okay.
Yeah.
Even if, go ahead, Gary.
Yeah,
Oh,
so
no,
I was going
Karis.
to add. Yeah, I was going to add because I don't want it to be lost that actually SAMHSA undertook this endeavor in 2017 to develop a national set of core competencies for peer support workers. And that was for peer support workers across the lifespan, meaning from youth to older adult, and both mental health, substance use, and family. So it was quite an endeavor. And I think that's a nice starting point to look at those core competencies. They are not written in stone, they're not mandates, and they're also not quote unquote evergreen, meaning they were written in a way to actually think about how might this workforce change over time and how do we make sure that we build in core competencies for the change. So for example, people are using more telehealth and using more telecommunication, if you will, in order to provide peer support and other services. So in California, we've added digital health literacy as one of our core competencies because peers are actually helping providers figure out how to use the technology, as well as helping people in community connect to telehealth and other uses of digital therapeutics. So I think that's one thing to think about. But I also think it's critically important to remember to talk to the people who are doing this work about their feelings about core competencies, certification, et cetera, and having multiple pathways. Community health workers, it is more state to state about whether or not there's a certification required or not, or if there's a certification. Same for promotores, and there's mixed feelings in the communities about core competencies, practice guidelines, certification, and making it more professionalized in that way. So I think we have to kind of work with these communities and these workforces to figure out how do we move forward on anything that's national based around core competencies, practice guidelines, or certifications.
Thank you. So we actually have another question. Somebody wants to know, how does this work for kids? Is there a way that these behavioral health support specialists, could they work for children? And are we doing any of this?
I've had some great examples from Ohio that we're just rolling out right now that I'd be happy to share. We recently launched a kids specialized managed care program called Ohio Rise. And we have incorporated paraprofessionals and peers into a number of areas of this. First, we have a mobile response and stabilization service that we just rolled out in last July. And we encourage the use of peers to accompany the licensed practitioners that are required to be part of that service. Second, kids aren't little adults. Just having them follow the same sort of treatment model and going to an office for office-based treatment doesn't necessarily work for them. And they're also products of their families. So in addition to having regular treatment available to them, we find it's really important for their care coordinators to have some experience in the systems that the kids and their families are working in, and to have peers available to help those families sort of navigate everything, because it's really complicated. If you're a parent that's trying to navigate schools and healthcare and mental health and disabilities and juvenile justice and child protection, you need someone who's really been there to help you with that. And so we find that peer support in that space is really valuable, as is the care coordinator actually working with the child on skills that are not necessarily about treatment. It's more about being involved in school and having social circles in this day and age when we're sort of only connected by phones sometimes. Really helping kids engage with each other, it seems to be part of the secret sauce.
So let's turn now to the model that Ben talked about, and that's community initiated care. It's a new but not new concept. We're doing it without knowing that we're doing it, but we really need to do it and do it better and do it more. So in addition to the behavioral health support specialists, we focus on this model in our report. As Ben mentioned earlier, it uses task sharing to provide informal training across members of the community and guide people toward clinical resources. And the example I often hear is, say you're in the barber chair and your barber strikes up conversation with you and asks you how things are going, and you indicate you're going through a divorce or whatever it is that is happening. And that person has a little bit of training, enough to know how to talk to you and also to know where to point you in terms of resources. So Gary, CIC, Community Initiated Care, is a relatively new name, but there's lots of evidence from across public health research supporting these activities. Our recommendations would help to operationalize and to test out this model. Can you please talk about how the federal government can leverage CIC models?
Yeah, and a lot of what I said before had in mind this whole notion of task sharing when I was talking about, spreading, being more ambitious about the skills that all these non-clinician roles can bear, and also to really try to relocate the work into community spaces. And you give a great example. We did some work at training barbers actually in depression counseling. There are just a lot of trusted people that are really eager to jump in to those kind of roles, and we know a lot about how to train them well and to do quality partnering about them doing it well and so forth. What we don't have is the infrastructure to make it the new normal. There are a lot of one-offs. I mean, we did in New York City, which I think was the most ambitious effort at scaling task sharing. We invested a lot of city dollars. We brought 1 or 2 dozen agencies to bear to manage different examples and programs of this in multiple settings. So we need an infrastructure. And so it's therefore especially critical that if we're in this moment going to think about and put more resources into redesigning, replenishing the mental health workforce, is that we replenish it in a way that it could be a home base to this kind of task shared model. And so that was my point about, mental health professionals that psychiatrists, psychologists, the more licensed group now, we underinvest in them. They can really be add to their toolkit, filling in these kinds of roles. That's been the basic model in where task sharing has scaled up globally. It works in all settings, in all sorts of places, far more resource strapped than the US. And it really works. We know competencies. We know the ways how to train. We have manuals off the shelf. In New York City, we did something called the Friendship Bench, which in Zimbabwe trained grandmothers to do depression counseling outside of primary care practices. We created friendship benches. We used their manual. We brought their training team over. The knowledge is out there. And when you start implementing these things, it really energizes neighborhoods. When you put something like a friendship bench, let's say, in front of churches, which we did in New York, it just really engages that voluntary community, that neighborly community, to then see what can we offer. We had volunteers from congregations. Well, I can train to be a counselor on the bench, et cetera. It just really changes the whole distribution of the work, the whole intersecting quality of the work to do task sharing. And I'm really thrilled to see that got a foot in the door here. I think it can also be part of the job description of behavioral health specialists to have more of that skill set. It's really a necessary antidote to our current mental health crisis.
So this is very interesting. Again, a name that maybe some of you haven't heard before, but we are doing some things like this, like the Friendship Bench. So what do we need to do to scale this? We at BPC in our report have recommended creating a demonstration program, demonstration grants to try this out. What else is needed, and what do you think a demonstration program would look like? What kinds of things do you think would be tried? And Gary, let's go again to you, and then we can also open it up to Karis And
I mean, I could give a forever answer to that question, but I think the key thing is to know that this has been done really well, and to learn from that. That you need to support the training function. How do you train people, and that's an open resource to community members. How do you build that? And there are lots of models to do that and to fund that. How do you reimburse and have a business model for mental health practitioners to be coaches and supports to that? And how do you train them? Because they were never trained to do that. But how do you train them to be that kind of coach and backup? There are curriculum for that. So it's very easy to do that. What I worry about is that sometimes US policymakers just want to plug in a thing to an existing system. And I think if we just plug behavioral health providers into the current system, or if we just laid out a demonstration project there that was home-based in current systems, is that the gravitational pull of how things have been will actually water down the innovativeness and excitement of them. One key thing we did in New York City when we seed funded these partnerships between providers and community-based organizations and networks was we gave the money to the community partners. We paid them to choose which behavioral providers they trusted and wanted to have a relationship. And then they created a way that they were going to work together with some technical assistance support so they could get off and running. And that's just an example of just being careful about the point that there is a shift here. It's not just adding more people to the room of the regular system. It's really changing the space and place of the work.
great. Karis,
Yeah.
Marissa, anything to add to that?
Yeah, I was just thinking about a couple of things, and that is, as Gary was talking, like, how do we learn how to do these things? So there's demonstration projects is one way to do it, and within any kind of project, creating learning communities and opportunities for people to learn, because I think and also for people to make mistakes, because what do? You learn from mistakes. So I think we have to have that ability for people to come together and learn how to do this from people who have done it well. When I worked for the Department of Mental Health in Los Angeles County, we had an array of peer support. They weren't certified at the time, but peer supporters, community health workers, promotores, and health navigators. And it was interesting, none of them knew the difference between themselves about what they were doing, and also the providers and some of the supervisors weren't clear. So by creating throughout the county across all of the systems of care, not just the Department of Health, but public health and health services, we created a virtual learning community of practice. And we utilized supervisors who were doing exquisite work in this area, and peers, community health workers, and promotoras. We actually had this little TV show that was like internal to our county to be able to help people share about exactly what is their role, how do they do it, and how did they get into it, and what training and core sets of competencies, and I call them also core gifts, like having an interest in being able to do this, so that there were plenty of opportunities for people to think about, oh, I want to do community health worker work. No, I'm really more fit to do peer work, so that they could have this variety. But most importantly, I think it's bringing together people, including your people who do quality assurance and billing and supervision, to understand what does that look like from people who have already done it and done it well with good outcomes. So I think that might be another thing to think about as well. And for the federal government, I would love, would love to see CMS have some clarity around the qualifications, because sometimes it's a little murky and gray. So for example, for peer workers, you have to be 18 and above. Well, why 18? Why not 16? I don't know, but there may be some reason. It'd be interesting to know what that is. And secondarily, it says high school diploma or equivalent. Everybody assumes equivalent means a GED. So if you don't have a high school diploma or GED, we might be leaving people out of the workforce, peer workforce, who would be exquisite at it. But CMS says equivalent. GED is just one sort of equivalency. How many others are there? So I think those kind of clarifications to the field will be super helpful in expanding the workforce and growing that workforce.
Marissa, anything to add here?
Not much. I think my colleagues said a lot of good parts. The only thing I'll add on is that this Medicare coverage of peers in certain situations or in lots of situations really can help push the needle with some of our commercial insurance partners too. As a state Medicaid agency, I know often our array of behavioral health services that we cover is much greater and much more flexible than everybody else's, but sometimes as goes Medicare, sometimes goes the commercial market. So it's really exciting for us to think about some of those practices spreading into the rest of the insurance space.
Great. Okay, in a minute, I'm going to ask each of you, what one thing would you most like to see Congress or the administration do to really push us forward in this area? But before I do that, we have one more question from an audience member that I would like to ask, taking us back to peer specialists. And this person would like to know if the panelists can suggest pathways for Medicare collaborative care providers to learn how to integrate certified peer specialists into teams so that Medicare beneficiaries can receive peer support.
If I'm assuming that's meaning collaborative care for depression and primary care, and I'll take that assumption. And so for those who may not be familiar with that, that's a model where a nurse or social worker usually is in a primary care practice and does these function of a depression care manager, does the psychotherapy, does basic follow-up, keeps in touch with the person, and that improves outcomes tremendously and the ability of primary care to treat depression. What's interesting in terms of that in this conversation is, for example, in New Orleans after Hurricane Katrina, they took that model and they had community members be the care manager, and the care happen in people's homes. And so many of our care models can be spatially re-engineered that way. If we think about our workforce in the imaginative ways that we're talking about here, if we try to fit these new roles into these already set models, then I don't know how much progress we're making. If we start to think of these models like collaborative care in new ways, in places that go everywhere in the community, then we're making progress.
Okay, let's take out the magic wands. Can I get from each of you, what do you think Congress or the administration, what is your top priority? What could they do, hopefully this year, to really move us beyond the licensed workforce? Again, not ignoring the licensed workforce. We know we need a lot more of these folks, but this is a team-based approach. So what can we do? What should our priority be to help move us in this direction where we're looking also at the community? And I'll start with Gary.
Well, I may get into bipartisan trouble here, but I would say, all this talk about the workforce is critical, but it's society that is hurting people. And so reinstating the child care tax credit, universalizing childcare would be the most powerful public mental health intervention that could be made by government. And so we really have to think about these other social policies and these debates that get red and blue to death in terms of their resulting tax policy, economic opportunity policy, all these things. We have to calculate their impact on mental health, because the inability to really think coherently together about a social policy that is nurturing and drives well-being is what's driving our mental health crisis.
Thank you, Marissa.
One idea that comes to mind is allowing states to use some of their administrative dollars to train a workforce that isn't there yet. Often we can do that to train an existing Medicaid workforce. So for, say, physicians or licensed folks who are already practicing in the field, we can help up their skills and sometimes draw down federal match for that. But it's not as easy to do that with folks who aren't yet serving people who are in the Medicaid program. And I think it would really help to have some dollars to put behind the training of this workforce and having folks work together, including the training it might take for some of Gary's ideas to come into practice.
Karis?
Yeah, so we haven't used the word trauma today. Not that I would want to traumatize people, but I think it's so important to understand the importance and the role of trauma in people's lives, especially during, and I'm going to say still during this endemic. So what place does that have? How do we understand it? And then how do we prevent it and also support people who have had traumatic histories in lots of different ways. And lastly, I think most importantly, it's about the culture of what happens within mental health treatment, that we talk about recovery, but we need a true belief in recovery. That will change the culture and the belief that these things are actually possible. Friendship benches, peers, community health workers, promotoras alongside our clinically trained and licensed providers.
Thank you. Again, you can find our report at bipartisanpolicy.org. Just went live this week. We're really excited about it, and we're excited to continue this conversation. Thank you to all of our expert panelists for a really productive conversation. And let's make the most of our workforce in behavioral health. The need is there. Let's look to the community. Let's start thinking out of the box. Thank you again from BPC. Have a good day.